Welcome to the Birth Lounge podcast, an empowering space for expecting and new parents to hear candid conversations with experts, support your mental health, and learn the tips and tricks that thousands of parents have used to craft their ideal birth. We will answer all of your questions, the scary ones and the weird ones, to help calm your fears and feel confident going into your birth. I'm going to help you redefine what birth and motherhood looks like and how to embrace your journey. I've intentionally crafted a list of experts to help you navigate pregnancy, explore your birth options, and plan for postpartum so that it can be a time of soaking in your tiny human. We're going to go there on all the hard topics so that you can dive deep into finding your confidence and freeing yourself from fears around birth. With over 10 years of experience in family education and a master's degree in human development and family studies, I created this podcast as a way to share the resources parents need to make educated and informed decisions about their care in pregnancy and childbirth. This is a birth community driven by evidence-based information and research in hopes to help you explore your options, understand your rights, and know what choices you have along the way when it comes to birth and beyond. I'm your host, HeHe. Now let's get to the good stuff. Hi, before I dive into this episode, I wanted to make sure that you knew about my free guide to Pitocin use. It's a PDF download that breaks down everything that you need to know about Pitocin use. What does the FDA say about proper and safe use? How do we typically see it be used in American hospitals? If those two things differ, what kind of data do you need to be aware of in terms of the different uses of Pitocin? Where are some places in labor where Pitocin actually might be useful? How do you know if you're getting too much, too fast? How do you know what the hospital policy is, plus what are your other options, plus what you can say no to, plus what you can request? Well, it's all in the PDF guide, and that's totally free for you. So you can go to thebirthlounge.com/Pitocin. That's Pitocin, Pitocin, and download that. It's a comprehensive guide, got everything you need to know, plus how to have these conversations with your provider to make sure that your birth goals are met and respected during your labor. Again, you can find that at thebirthlounge.com/Pitocin. All right, now on to the episode. Hey y'all, and welcome back to another episode of the Birth Lounge podcast. All right, one of my biggest motivators in life, in business, in what I truly do believe is like my calling, why I was put here on earth, is to help women understand that having a baby can be this very beautiful, harmonious, gentle, supportive, transformational, life-changing event that involves zero trauma. You can literally walk away feeling so empowered, so proud of yourself, so confident, 100% just knowing that that was exactly what you needed. And I want that for you. I want that for everybody. Actually, I want to restore birth to what it was truly meant to be, where it is not this dangerously over medicalized event. It's something that's considered normal. For low risk births, I'd love to see it done at home under the care of midwives. For our high risk people or people who need the skills of a surgeon or a, higher trained medical provider like an MFM, then those people would be assigned to the correct medical provider. You'd see an OBGYN or you'd have an MFM and you would deliver in the hospital. I would love for it to be a family event, meaning that if you have other children, they're present, they're part of that. They're also experiencing your family growing. And this is just so hard to find in OBGYNs. It's really, really tough to find someone who believes in the sacredness of birth, partly because in medical school and just the way that the US healthcare system kind of portrays it and views it and incentivizes it, it turns birth, and it's often taught that birth is just a medical event. It's just something to come in and do, and it's very systematic, and it can be, almost put on this conveyor belt, and everyone's birth can receive the same consent and the same information and the same care and the same steps and the same methods And that's just not the case. Every birth is as individual as your fingerprint. And today's episode, I have the honor of interviewing Dr. Darrell Martin, who is an OBGYN and a fellow of ACOG and a gynecologist who believes this. He really, really sees the just beautiful sacredness of labor and birth. However, his career has not been without challenges. In today's episode, you're going to hear how he actually pioneered trying to work with midwives in a hospital setting and was literally blackballed from the medical community and then run completely out of town. Unbelievable repercussions for trying to push back on the medical system to improve the results for moms and babies. Now, this was in the 80s. So here we are, decades later, finding out not only is this still true, but he was right all along. Now, this episode is actually just part one. We are going to dive into the trends that he has seen throughout the years of practicing OBGYN for so long. We're going to talk about hospital policies and his opinion on inductions, plus how he built collaborative care between his patients and himself. Stick around for next week because he's going to actually be back for a part two. But without further ado, Dr. Martin, welcome to the show.
Thank you. I enjoy and look forward to being here.
Absolutely. I'm so excited to have you. We have spoken before on the phone and we were chatting about kind of our philosophies, and you've written a book. And now, before recording, we just chatted for 45 minutes where we should have been recording and we were just talking about our experiences in the birth world and our current healthcare system and the care that women and families really do deserve. So I'm very excited to have you here. You are a retired OB. You really love and admire the midwifery model of care. You believe in patient autonomy, and you have this mission to educate women to seek out this collaborative care prenatally, but even before that. Tell us about your career. What got you into obstetrics? Have you worked with midwives in the past? Why do you have this love for the midwifery model of care? And tell us how that kind of played out throughout the years of the ever changing healthcare landscape in the US.
Well, as you mentioned, I had written the book, so it caused me to go back in time and kind of review my life in that form of a journal, very analytical perspective, and it caused me to remember a lot of things that I had forgotten. One was my uncle, who was a family practitioner, and I would have to say that's the principal person who led me into medicine, notwithstanding the fact that I was an only child and my mother was pushing me in that direction as well. Maybe because of the competition with her sister-in-law, since my father, at least at that point, was an undertaker. The joke back then for my grandfather, we were all Italian, and he came over on the boat and built houses and was very proud of his two sons. He could only afford to send one to a college, and that was the oldest, and that was my Uncle Lee. My father was then the undertaker. The quick story is that someone thought they were joking with him in our little town and said, you have one son who kills them and the other son who buries them. And he proceeded to knock the guy out there, right there in the middle of the street, take him out. I always saw him as mild-mannered until I heard that story, that he was very protective of his two sons. So the son who was a physician, Uncle Lee, practiced his whole life in Arlington after being in the military, and in fact was the physician to President Truman, Vice President Truman, and the General MacArthur and his family. But anyhow, when he would come back to town, he was treated like a god. Really, back then there was tremendous respect, but as a family doctor, he really connected with people. Very soft-spoken, very concerned. He would bring samples back by the bucket loads, it seemed. And I would watch him on my grandmother's front porch, who we lived next door to, and people would just come who he had taken care of before he went off into the service. And he would still be he was there to vacation, to see his family, and he would talk to them, help them, give them samples. And so that connection that I saw was just incredible. And that's the original. If you want to talk about what a great O would be a fellow who understood family practice. And he made house calls until he was in his mid 80s. And his son became a physician and did the same thing. So that was my connection to medicine. And admittedly, the episodes of care I needed, from appendix, tonsils, etc., I was treated special because initially they were referral sources to my uncle. I didn't understand that. I got some VIP treatment sitting on the lap of a physician when I was little. So the connection was made back then. And so I always knew I wanted to do some form of medicine. And when I went to medical school, I think there's some things that impacted me. I like the aspect of OB. As a medical student, you go to all the different specialties and you want to be that. I wanted to be a neurosurgeon. I like the idea of operating. And even when I was at Vanderbilt, they tried to talk me into moving over from just general surgery and then OB to neurosurgery. But that was a little too much technical for me, to the extent that I like the patient contact. I like the aspects of normal obstetrics, and yes, some surgery that's defined, that usually, like I joke and say, that you have a bad back and you operate on it, they may still have a bad back. You have a bad uterus and you remove it, they're not going to complain anymore. It's more defined. But yet you have experiences, and I've had patients I saw for 35 years. And so it becomes much more of a connection than it is when we started in practice, like 73. It was always about breast, pelvic, pap. It really, that was all that was centered in. It was all technical, because you wanted to make sure that you knew the technical in case something bad happened. And so you tended to forget the normal in that. Everything was about, in residency at Vanderbilt, it was like, can I do these forceps deliveries? Do you want to make them happen so that you get that training in case you need it? Back then, we were doing a lot of breaches. I did many breaches and breech extractions and hyperforceps, blah, 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 and a lot of twin deliveries. We didn't think anything about automatic C-sections. So when I was a senior and resident and then chief resident, we worked at multiple hospitals, which was great. And one of them was Nashville General, and the residents pretty much ran that city hospital. And so we had an indigent care program there for poor people that didn't have insurance, and it was run with midwives. So we connected, and I was responsible through those couple of years with the midwives, and I knew a couple of them and was friendly and socialized with them. And I saw the care being markedly different in the outcomes with the interventions that were occurring by my peers, and then you start wondering why. Automatically do a episiotomy. Why do that? Why is that really necessary? There was no logic as I delved into that, to say, yes, it's going to speed up the delivery maybe, but is it necessary? That can't you repair a tear if it happens just as easily, and the muscles have really split? You're not really hurting them by not doing an episiotomy. So many of the interventions that we did were just because someone told you to, and there was no science to it. It was just do it because other people have done it, and there was no studies. And I almost went to do a PhD at North Carolina to do exactly that. And when we toyed with that idea, and that was because of the issue in Vanderbilt and in Nashville, where we were blocked with midwives, Art Miller was the chairman at North Carolina. He said, you come here, you can be a chairman someday and really do the studies that disprove what these people were trying to do, meaning traditional obstetrics. And I said, but then I don't get to take care of the people. So that was why I stayed on the path private practice. So seeing the midwives, I said, this is the way I want to work. So even when I started in private practice, fortunately, it was a new hospital that I went to. I was also on faculty at Vanderbilt at Nashville General, still working with the midwives. And so I got to make the policies and procedures, because you can make the policies and procedures if there's no other physician groups. Anytime there's competition, sometimes, i.e. in this case, other obstetricians, they don't want new things in because they might have to do them themselves. They want more control, and they would block you. And that's a legitimate way, unfortunately, that they can block you with rules and regs at a hospital. If there's 10 that are going to stand over here and say, no, you can't do that, they're going to force women. And that was happening back then when I tried to get the midwives in at another hospital through all of that politics, that they were going to stop the birthing room, force episiotomies, force preps and enemas, ridiculous things just to block people from using the hospital because they didn't want to do it. Yes. Now this is 1979, 1980.
But that still happens today is the thing. There are still those games that are being played in the hospital and the politics that influence policies and the care that's being given, that the person that pays for all of that is the patient and their outcomes and their
Yes.
experience.
That's why I've evolved into it, and we can talk about a little bit more about it later because we're jumping ahead, but where I've evolved to birth centers is the place, because as long as they're not run by a hospital, anytime it's run by a hospital, the hospital is going to want the money, and they can change the rules at any time.
And they run it like a hospital, and it loses the specialness of a birth center.
Yes. Yeah. And all of these things, even in 1980, they would argue against them because they were unsafe. Now, they didn't have any documentation that they were unsafe, but they would say that, and there would be enough of that voice out there that the uneducated to medical things clients would buy into. And if it wasn't even them, they're young, so what do they have? They have a set of parents who grew up in that era to believe everything a physician said, and grandparents. And then you're in labor and you have a family with 8 people there. Half of them are men who don't want to be there, and they're stuck in the waiting room, and they say, this is taking too long. When are they going to do the section? Because they want to get out of it. So you got to deal with sometimes family that are uneducated putting stressors on. So anyhow, we were going along, and the midwives at Nashville General were getting repeat customers who now had insurance. Oh, you can't use the indigent care plan because you have insurance. So you can't come to Nashville General to have a midwife do your delivery, because there were no midwives in Nashville other than at Nashville General Indigent Care. So they were blocked. Some physicians' wives wanted to have the births. So we started talking about that. Susie and Vicky were the midwives, along with myself, who ultimately sued them. And they said, let's start a private practice. I said, that's cool. So we tried to first do it at Vanderbilt. And we tried to do it under the guise of we were going to educate medical students and residents of a different way of doing things, and start teaching them firsthand what it's like, rather than just leave an institution and not know anything other than whoever they go into practice with, probably, who's older and just established and plays by their rules instead of changing things. So we tried, and then they stopped. So that's when they stopped at Vanderbilt, because we were also, of the other hospitals we were using, one was a city, was the private hospital. And so those physicians politely behind the scenes told the chairman or our faculty at Vanderbilt that if you have to make the choice about bringing your residents to the private hospital or the choice of having midwives at Vanderbilt. And so Vanderbilt needed more places for their residents to deliver, so they chose to keep the private hospital and not do what we wanted to do at Vanderbilt. So that meant we had to do it, or try to do it, in a private setting. So we thought, this is pretty cool. We can go up to Hendersonville, where I was the only physician with 2 partners who were all in, and get it accomplished. Well, ironically, as this was starting to happen, the physicians in Nashville started picking up on it. And The malpractice carrier in the state volunteer mutual was physician owned. So physicians were on the board, physicians controlled who had insurance, right? So they actually had, and the gall sometimes of people who just verbally say things out. These guys that grew up on the, in quote, right side of town, I'm being a little sarcastic, were Belmead, which is the place in Nashville years ago. It's not so much now. Whatever they said was like, oh, you got to listen to us, right? So they had the nerve to say, or one particular fella who became on the board of the state volunteer mutual. So he got to make decisions, right? So he went out there and said he was going to get my malpractice insurance in public, in front of nurses. They did. They did take my malpractice insurance. That was what the book is about. That's what happened. I got basically kicked out of town because the only malpractice insurance was through the physician-owned carrier. And they said I was operating in risk of undue proportion because I was working with midwives. Yes. Now that's 1980. It's happening. And so I got booted out of town, and that took my journey around and ultimately ended up in a hospital that had 5 fellows who were doing deliveries, all of them over 55, all of them ready to retire. I went with one of the fellows, and they could care less what I wanted to do. So they were cool. And as long as you're taking call, because we had a large indigent group, as long as you're going to be on that call schedule, I'm good. We're at the end of the game. So they let me start midwives, birthing rooms, ultimately a new OB hospital. We, because of Emory backing away from doing the indigent care, they came to myself and there was one other partner at that time who had joined me. They asked us to take over the project. So we didn't have much choice. We weren't going to go anywhere else. So I said, okay, out of faith. And one of the midwives that got booted out with me never really practiced. She went up to a birth center in Delaware and got married and worked up there. Through a whole series of circumstances, I was also on the board of a private school, and I was encouraged to hire her husband, not knowing that I would need her. We already had midwives in our private practice. We already had 4 or 5 in our private practice. They were doing the majority of the births. At that point, in retrospect, I would have done it differently. At that point, we were giving people the choice of midwife versus physician. Today, I don't, if I was starting again, I wouldn't do it that way. At that point, I was doing more talking people into using a midwife without forcing them to use a midwife. I would use the old argument. They would say, is it cheaper? And I would say, no, actually, it should cost you more because you're getting 2 for the price of 1. So you're getting a deal. And I would explain. So I saw that early on, that it was part of educating people to why it was important to use them as opposed to me.
Mm-hmm.
Now, it also helped at some point when I had 3 other partners who were women and I was the only male. Some bias was they would want a woman. I think I can do it just as good. I haven't had a birth, but I think I can be as good, if not better, at some of those aspects. But you know what I'm saying. And so that helped to move some people. So I'd say 95% plus of our births were done by the midwives. And then call me up, we've got to take over the clinic. So out of faith, I did that. One of the midwives, that because I had hired her husband for the school, that was Vicky, who I was trying to work with in Nashville. Ultimately, 15 years later, we started working together, and she ran the indigent project for us. And so at the peak, we were doing 175 births a month.
Wow.
Yes, with probably 12 midwives, 3 nurse practitioners, and sometimes only 3 or 4 physicians. Now, when we were on call, we just stayed there because we also had to run the ER. But our section rates were below 5%.
Wow. Wow.
And that was an interesting story because we now had this really nice brand new facility for birth. We had 2 outstanding neonatal people there. And Dr. Velez, it was Paco Velez, he came to me one day and he said, Daryl, he said, we've got a problem. What's that, Paco? He said, we have these monthly or quarterly meetings in town with all the hospital neonatologists. And our numbers are consistently better than anywhere in town. You have the lowest section rates, the best outcomes. And he said, you've got a large indigent group, and you should have worse numbers. He said, I'm not having enough sick babies in our neonatal unit. It's true. He said that to me. I laughed. He says, where are you sending them? I said, I'm not sending them anywhere. We're doing them all here unless the baby requires immediate surgical intervention. And then we're going to have them birthed at Emory where they can go right into the OR for pediatric surgery. And he said, no, that's not true. You're sending them. He would still to this day not believe that we didn't refer them somewhere because our numbers were too good. And they were too good because of the care that the group of midwives, it wasn't me, we were supervising. We were trying to stay out of their way most of the time and just listen to them. And they asked to do something. I knew them well enough that I didn't have to go into any big, deep, detailed questioning for them. And my philosophy of teaching was always that way, in that as I love to teach the nurse practitioners and the nurse midwives, they would ask me a question. I would never answer the question until they told me what their answer was. Because once I knew what they were thinking, they had to give me an answer. And then I understood a whole lot. Rather than me just give them the answer, let's see what they're going to say. And sometimes it may be I learned something, or I might move in their direction because it's not going to affect things. And that's I like to teach that way. I want to hear what you have to say so I understand where you're coming from. So that journey was essentially the journey through my career. And then, of course, had to stop doing births because of needing a hip and knee replacements, because I was a marathon runner. And that was my release. Particularly, it was my release when I was kicked out of town. Running was my escape to do that, and passion, and eventually had to shut that down. So then I did more robotic surgery. But yet I still missed it. I still missed I couldn't, with a group of physicians, I couldn't intervene and relate to the midwives because I wasn't doing the births. So that, even though I was practicing for another 12, 14 years doing gynecology, and I was the managing partner for the whole group, I had some input, but I really didn't have that direct relation to advocate for them. They could come to me and I would try to play referee between physicians and midwives, because quite frankly, most of them, unfortunately, I would say we're a very successful practice. I don't think that I honestly hired anyone who came into the practice with a passion to work with midwives. They came because it was a successful practice and they could earn a good living. And oh, by the way, there's midwives. You had to train them. Some of them you trained, some of them got it, some of them never got it. And there was always those little battles. The regret is probably when you're successful, you get bigger. And when you get bigger, it's not always better. And you can't control 5 or 6 other physicians, very well trained, outstanding institutions, but didn't have the connection with midwives in their training. Now, what Vanderbilt is doing, what I understand, particularly as I've written the book and talked to some of the professors at Vandy in the midwifery, I'm talking about midwifery professors. I'm not talking about physician preceptors or professors. They do directly have the midwives training medical students and residents at Vanderbilt.
Nice.
And that's going to be the way that the connection occurs. And ironically, all we wanted to do in 1980, Vanderbilt finally decided to do, and then they bought a birthing center. Could have done it a lot earlier. It's listed at least as one of the best, and not the best, midwifery programs in the country. And I've gone back 3 years now, and we give them at their graduation, we talk to them, and the attorney who handled our case had been doing that for quite a few years and jumped on board with them about 3 or 4 years ago. And it's fun. It's fun talking to them. But it's still, most of them, quite frankly, when they go out and you talk to them, it's the expense of going through school is so great that they end up working for the government in some way. They're not usually initially not in private practice because they got to pay for the expensive education.
Like everywhere you turn, there's some sort of roadblock or there's some sort of systematic something where you're like, oh, that makes sense, or I'm pigeonholed into this decision, which is so unfortunate. It must also feel bittersweet about Vandy starting that program. Bitterness because you're like, I tried to tell you literally decades ago. I tried to do this for you, and I had the answer the whole time, but also sweet in terms of, a little bit of, I guess, validation in that you were right the whole time. And, regardless of when it came to fruition, what you know is right for women and families is finally being done at Vanderbilt.
Yes, I think that's definitely true. And I understood that internally in one-on-one discussions with some of the professors, some of the private practitioners who were just out of residency, they totally agreed with what I did. Now, most of them were scared to death when I was attacked, so they weren't going to either back me up, or they saw what happened to me. They're not going to take the risk. And the institution needed to have births to have X number of residents in the program. Strength of the private practice politically was greater than the desire to put midwives on board at Vanderbilt in 1980. And it took till the suit was settled, 93, 95, there were no midwives working in Nashville. Because that was the bad part of us having the litigation, was finally when it was headed to the Supreme Court and things were settled, they then decided to open up with midwives in Nashville. So I understood it was politics on the part of the fellows that I was trained with, men and women. They understood, but they weren't going to risk their career. And I didn't even realize that I was risking my career until it had happened. And what one of the consequences to pull on the plug on your career with 3 kids under 4 years of age and a wife to support and try to help. And there was my passion. So I never lost the passion. It was just, it took me a while to get to the right place. I was never bugged through all that career of what to do and not to do in terms of the hospital setting. And we were okay. I was too busy, in quotes, to think about doing a birth center. My always discussions would be, we're going to try to make the hospital like a birth center. We're going to try to make sure. I said, for the most part, I can guarantee it. I can't guarantee it 100%, but we can make it as good as we can make it. And there is that little bit more of that safety element. I didn't try to scare them. Some of my partners wouldn't see someone who wanted a home birth. They said, I don't want to get involved with the litigation of that. I would see them. It's just giving care. It's not, they're so fearful of, I was never afraid of being sued. I just do the best job I can. And you're going to occasionally miss things. People do that. But if you rush too much, you're going to miss things. If the electronic medical records can be your good and they can be your bad. You know that because you can click on things. It doesn't mean you've gone over it just because you clicked on it, right? It's a different world. I just want people to have choices, but I'd like them to make informed choices. So I think that would circle back to the more the people like yourself who are doing things before they get pregnant, gets them to make better choices. I think they get more comfortable with the choice because they're on, once that pregnancy test is positive,
the race is on.
The race is on, and they should meet their provider before they're pregnant.
Yeah.
and they should know what hospital they're going to birth at before they're pregnant. And they should
So let me stop you right there. What are
Okay.
we looking for in a hospital that we want to birth at? And where do we find these things? Something I'm familiar with is leapfrog.org. I think a lot of people are familiar with that, but it is self-reported by hospitals, so that's one thing to know. And not all hospitals are going to participate, so your hospital may not have any data. So that's another thing to know. When we're looking into where are we birthing, what kind of things should we be thinking of?
Well, you start with the basic. First, is there only one hospital in town? Do you have a choice or you're not? You may not have a choice. Then you want to know what the rules and regulations are at the hospital. Now, you got to know what questions to ask about that. And so that's getting informed before you get to that point. You got to know, is there one physician group or are there multiple ones? Do they have a birthing room? Do they have a birth center? Don't don't necessarily trust the physician provider to say, oh, everything's going to be okay, when he knows that he's up against a battle sometimes, because he wants the economics of the fact that he wants more births. So he has an intentional bias that's unfortunate, that if he says, no, we can't provide that there, he may know that, but he may hope that you just tend to ignore that. So I guess in the ideal world, you're going to have a list of the things that are your hot buttons because you're prepared. So when you pick the hospital, you have those buttons. And maybe you find in that town a doula who knows what those rules are that you can trust because they're objective. Maybe you find a labor and delivery nurse who knows what the rules are and they're objective. I'm not sure that an employee of a practice is that objective, because if they get it, what they say may get back to their boss and then they get fired.
They can't say everything either. Some things they are just not, they could not tell you that.
Yeah, most of them would not be HIPAA protected, but I don't think that you can, as long as you're not talking about a patient, you're HIPAA protected if you say that they're going to require inductions. For example, you want to know for not only the provider that you're going to see, but the provider who may deliver you, that's a big question. Or do they work by, nobody works by themselves. So they're gonna have someone else that takes call with them. So you better find out who that is, and that person may not be aligned with you, and all you've discussed it with is the midwife, and the midwife is going to have to roll, at least initially, with their physician boss. And if they conflict with them too much, they're going to be gone, either because they're angry and they're not happy in that situation, or they're let go because they're confronting the physician. They're questioning, why are we doing this? Why are we doing that? So the more, that's part of the hospital. If you only have one hospital, then is there a birthing room? Then is there a birth center in town? And then, so that's a starting point. That's what the kind of questions you want to the hospital. What are the rules? Are they going to require you to have an IV? Are they going to allow you to ambulate? What are their rules on inductions at the hospital? Do they do the medicine that goes by standards? But, and I'm escaping me of what that is, the standards that typically they should go by, but we know they're often bypassed for inductions, right? They have to be medically indicated. But if a lot of doctors are doing them for convenience, they're not going to tell on each other, right? Because if you can do it, I can do it, right?
Wow. Makes me want to cry.
But it's a way of life. And I see it, someone has a natural connection with the physician. I'm just sticking on the physician for a while. Probably doesn't happen as much with midwives. And they want that physician to do their birth. So the subtle buy-in then to that client is, I'm on call on Thursdays. The people I work with are on call on Monday, Tuesday, Wednesdays, and we take weekends, 1 every 4. If you really want me to do your delivery, and you don't want to meet these other people and you won't know them, we can do your induction on Thursday because I'll be there. They're there and they're not there. They meet you in the morning. They get the Pitocin started. They come over and see you at lunch. They pop an epidural in if you're moving on so they can slow things down so that you can deliver after 5 when they're done in their office. So I think a big question is, are you assigned to a hospital one day? Theoretically, if you're the physician who's not going back and forth, you may allow them to labor longer. You may allow things to flow a little better, right? If they're going back and forth to their office, they don't want you to deliver while they have patients there. That's always been a big aggravating factor for years. I'm waiting for my OB to come see me for 3 hours because they were overdoing a delivery. Now, epidurals control that, right? And then if it's
Wow.
And then at 7:00 rolls around and they're done at the office and they come over. So you're not progressing as rapidly as you should, maybe because I'm loaded with all this meds. They don't say that. And then maybe it's better that this baby's kind of big and you're not going to birth. So maybe we ought to do a section. By that time, someone in the family is going to be all buy in on that, right? Now, you go the midwifery direction, hopefully none of that occurs because typically they're there 24/7 or 12 on, 12 off, depending on the number of midwives they have and how many hours a week they work. But I've seen midwives work one way and I've seen midwives work another way. And I've seen midwives who work in practices where, unfortunately, if that number has changed from 10 to 12 births a month to up to 15, and it's been back down to 8 to 10. And those are arbitrary numbers. So it's really based on how many hours you're going to spend with somebody, right?
Yeah.
But gosh, with 12 deliveries takes care of the overhead and my salary, anything over that is pure profit, right? So if I do 15 this month, all those next 3 deliveries are profit. So there's no overhead coming out of it. So that all can come into my pocket. And that's whether the midwives run their own practice or whether they're in with the physician, right? Unfortunately, there can be that financial incentive to increase the number of births per month. And then what does that mean for labor support? Because my old way of thinking things, if you're going to have a midwife, they should be there with you. And they got to go to the bathroom. And occasionally they're going to have 2 people in labor. So they're going to have to go back and forth during those circumstances. But they're not going to go chill out in a nurse's station and pop an epidural, right? And then come back in when it's time to push.
Did you see that? Did you see there must have been a time in the healthcare history of the US where you started to see that shift to epidural use and then seeing it be used almost coercively?
Yes. First of all, I did a lot of epidurals when I was initially in private practice. The anesthesiologist wouldn't do epidurals. So
Why?
they didn't want to get up in the middle of the night. And it didn't pay them enough.
Gosh.
They wouldn't do them for C-sections. I did epidurals with 0.75 marking before I knew it could be dangerous. I did the epidurals for sections. I did my own epidurals. So I knew how to do epidurals, and people wanted them. There, I was just trying to make it, right? I was an employee, and I was trying to figure out, and that was my stop on my way to do what I wanted to do. If I was working for somebody else, that guy, when I was working for him, unfortunately, I got too popular. And he liked midwives. He brought a midwife in. But that was about the time that the suit was really blowing up. As I had to sneak out of town. I didn't have malpractice, so I couldn't practice. And I was interviewed by Ed Bradley for 60 Minutes and Dan Rather for CBS News. And so I was popular there in a good way, but not to this physician. Jealousy does a lot of things in a lot of ways, in a lot of places.
Yes, it does.
Yes, pretty bad. But anyhow, so that's where I did my own epidural. So the question is, initially they weren't so active because anesthesiologists didn't want to come in and do it. I can remember initially even when I couldn't do them, I wasn't allowed to do them. And the anesthesiologists were at home. And I get these, they then call me. I said, she wants an epidural. And then the anesthesiologist would call me. Well, how far dilated she is? I said, if she's too far along, then I won't make it in time to put the epidural in. And if she's too early, she's too early. So I just make up what they were. Just come here. Just get in here. And those are the few. There weren't a lot, but that's how finally we had that big battle. And then now it's a matter of bigger hospitals without midwives. We have a hospital which probably does at least 1,000, 1,500 deliveries a month. And it's in and out. Section rates, 35%. Induction. There's a midwifery group there, but they're doing 15 to 20 births a piece. So really, I saw my daughter-in-law first birth was there, and they didn't know I was a physician, and they certainly didn't know I was an obstetrician. I was there, and she allowed me to be in there because my son turned green, and she ended up with the midwife back and forth, rarely was in the room, check her every hour or two, blah, blah, blah. And she ended up with a episiotomy and a 4th degree. She ended up, they sent her home the next day, which I didn't think she needed to because she had hypertensive issues. And then she came back the next day with preeclampsia. So it wasn't the optimal midwifery experience because they were doing about 20 births a piece per midwife.
Per month.
Yes. Yeah. Way more than to give the kind of care that you would expect from a midwife. Mm-hmm. They were rocking with the system. And those bigger hospitals sometimes are systems because they got to get you in and get you out. Obviously, if a person has an epidural, that's going to drive a lot of income into the hospital. Meds, more money, right?
Do doctors get paid per birth that they attend?
If it's their patient/client, they get whatever the maternity obstetrical fee is. If you're talking about if they're sharing call, that fee splitting is a delicate balance. So they just say at the end of a month, I did 5 deliveries for you and you did 3 for me. Is it all going to come out in the wash by the end of the year? There's different ways to do that. If they're all in the same practice, I've seen practices where, like in our practice, all the money went into one pot. So there's no incentive or disincentive to do, there can be a disincentive to do a delivery, but there's no incentive. And I've seen practices break up because one physician, if you eat what you kill, they're going to try to talk people into being induced on their day. And then that creates, you know what I'm saying, that then money becomes a factor. We try to avoid money becoming a factor. I think, again, things I would do differently is not get as big. I would have profit sharing with the midwives. You don't want them leaving. You want to treat them fairly. If I don't do any deliveries, then I'm essentially a consultant. And that was way back when I was doing the practice with the midwives that was blocked. Part of the thing that blew the mind of the physicians was I was going to be the midwife's employee. They were going to pay me a consulting fee. They were going to run their own practice. In 1980, this is pretty revolutionary for back then. They were going to pay for their front desk person. They were going to do everything other than I would be their consultant. I might see them once a trimester, consult whenever they needed to be. In my case, when I got kicked out of the practice, I was in their office until we totally got terminated. And interestingly, our office was on Music Row in Nashville. So right there with all the country music people. But yeah, I thought that's the only way you keep people on board. They do the work, they deserve the pay. There can be legitimate discussions about who's paying for all the equipment, who's paying the lease. And so the more vested you are, the more you're going to stay. If you're just, I shouldn't say it though, if you're only an employee, you may get tired and say, oh, I don't like the way they're doing things, so I'm going to go somewhere else. But that's not good for relationship with clients and patients. So you want some consistency. If they need to be off for a while because they're going to have a baby, that's fine. But you don't want them, or their husband they're married and their husband moves from Georgia to New York, they got to go. That's a good reason, not because they're mad at you and you da 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 da. They're not feeling they're paid enough. They work too hard. Those kind of issues. As much as possible, that's why I'm totally for collaborative practice. And collaborative has to mean some financial vesting for everybody.
Yeah, I think that's a great place to wrap this first part up. I want to hear your definition of collaborative care between a provider and a patient. What a client and a doctor's relationship should look like if it was an ideal relationship preparing for your birth.
Okay. So you're talking about the collaboration between me and a patient who's now pregnant. Is that what you're talking about? Okay.
Yeah, just
So,
what should your prenatals look like, and what will that communication look like, and what kind of things should you be hearing from your doctor when you meet with them to let you know that you have found a very good, respectful provider that's going to help you get the birth that you're hoping to achieve?
and you're making the assumption that I'm a physician who doesn't have midwives, right? Is that fair?
Yes.
Okay. First, I would want to, if she's coming to me, this is her first prenatal visit, right? Is that
Yes.
okay? All right. So I would try to develop, if I'd never seen her before, if she wasn't one of my gynecological patients, because that would be treated differently, because I would be advocating way before she came in pregnant that she really get educated to help make some informed choices. So I would start with saying the first concern would be developing a relationship of trust, because the more that they trust you, the less anxious they're going to be. I would use that. It's a tiresome thing that I'll say is, I want us all to be in the same bucket together. I don't know all the answers, but we know that birth is a wonderful thing. We know that you're excited. I know the more you know, the better your experience is going to be. And so you need to explain to me, and we need to work together on what you already know, because you're already pregnant. So then I've got to go over the basics. We want to know early on how far along you are, because the earlier you establish that, the margin of error greatly changes the bigger the baby gets. The margin of error of any ultrasound, maybe over 20 weeks, can be a week or 2 weeks, but it's not like that when you're 6 weeks along. So want to establish with them when the real due date is. And the earlier you do that, the better. And whether you incorporate, you're going to do the basics with them, like when was your last menstrual period? Were you coming off pills? Then I'm thinking, was their ovulation delayed? This day and age, everybody does pregnancy tests. In the old days, I would say, if you've been on a temperature chart, because, and if you're a biphasic temperature chart, that's one of the most accurate ways to know what your EDC is going to be, because we need to know that now, not later.
When you say EDC, define that for us.
Expected day of confinement, or
Oh,
expected delivery day.
got it. So an estimated due date.
Estimated due date, yeah.
Got it.
We
Okay.
used to say EDC.
Got it.
Add that confinement part, which is connotes a bad word, confined. But
Conception is a better one.
yeah, it's probably, no, it's definitely a better one. So in that visit would be to try to see how much information they had received before I saw them, because they were a newbie. Try to explain to them that I have midwives in my practice. I want you to have the opportunity to meet them. I've often said, on my good best day, maybe a C plus midwife. I'm not an A. I have too many other things to do. I accept the challenge sometimes when I would work with the midwives to see how much of that I would do in labor and delivery support. It's a tremendous emotional feedback to do that. The best thing that you do with a couple. And I can still see some in my mind that I know and I still see them. So those are great memories. But I would try to establish what I can and what I can't do for them.
Mm-hmm.
I said, you being in the bucket means you need to help me understand what you already know and what your expectations are. And I'll say, the most important thing is our trust. And the next most important thing is that you don't have expectations that could change and you start to feel guilty about them. Because I've seen that enough that it makes me sad. If their expectation is to go in a certain direction and things happen, they feel like they're a failure. Or maybe a family member, unfortunately, makes them feel like a failure. And then they end up with postpartum depression. The things that the first most important thing is we're going to have a healthy, safe delivery. I can do that a lot of ways, and we can do that a lot of ways. We don't have to do episiotomies. We don't have to do this, but I'm going to explain everything to you. And when it's calm, cool, and collected, we can explain as long as you want to explain, and we can talk about it to get to you having a peace about what that is. However, there could be a few things at the end that we need to have enough of a relationship that you're going to trust me. If we say we got to go, we got to go, and there's no stress. You trust me. So you got to help to develop that sense of trust from the very beginning. Now, that's where I have now more of a problem with the bigger the practice. There's too many people to have to trust. The less is more. I think it's better to be smaller. Then you're not, I found that when you get too big and they see different providers and the providers are looking at that electronic medical record, they're not even paying attention to the person. They sometimes don't review it before they get in the room. So they ask the same question that was asked the week before or the month before. And then what does that patient and her husband think? You don't care about me. You didn't even bother to look at my records. You're asking me the same stuff that was asked a few weeks ago.
You're just another number at that point, and you can
Yes.
feel it in the care that nobody truly knows who you are or what your story is or what your goals are.
Yeah, exactly. And then that breeds a level of distrust. And if the husband isn't there, they go home, well, how was your visit? And then they rattle off, so that you've never maybe met the husband. Maybe he's working all the time and he maybe came in one time for an ultrasound. And if you have an ultrasonographer, you're not necessarily doing the ultrasound. So you haven't connected with him at all. So he's developed a level of distrust. He has probably less vesting in the education ahead of time. He's not doing as much in terms of that study. I've always advocated the more that the partner was involved ahead of time, the more they're going to be involved after the birth. If you want to help when you're nursing, if you want help when you're dealing with all that, get them involved early, and then you're more likely to have them involved later.
Okay, let's stop there because I want to dive into that in the next episode. But before we go, you've mentioned your book a couple of times. So if people wanted to grab that, where would they be able to do that?
The title, there's a subtitle, but the basic title is In Good Hands. And it's available on Amazon. It's available at Books A Million. It's available at Barnes and Noble. It's available on our website. And in good hands, it's because it's a delivery. On the cover is a birth. And the birth was in 1979 that I was forced to do for the midwives weren't allowed to deliver at the hospital. So I had to do their client. And there are 4 sets of hands in the picture and that are on the front cover and at the birth. And that's the mama's hands, the baby's hands, the daddy's hands, and my hands. And yes, it was incredible. It's incredible. And it was on the front page of the Nashville Banner back then. They printed that picture. So that's the cover of the book. And the neat thing was that when we did the book launch, the couple still were in Nashville, the couple that we did the birth for. And they were there at the book launch, got them to sign the book. And their daughter, who now was a professor of psychology at Vanderbilt, was there as well. So the baby I birthed was there as well. So it was full circle, got to meet all 3 of them again. And they think I'm the greatest thing since sliced bread because I stepped in for the midwife and I accomplished under a lot of prying eyes. We were being watched quite carefully as to what I was doing and wasn't doing. They were looking for something to be able to
hang you up on.
Oh, yeah. Yes. They were all very interesting. couple stories, and maybe I'll share one with you. It was pretty funny after the fact that led to a big confrontation with the physicians at the hospital, but maybe we can throw that in. So it's a funny story. It's a very funny story. That was a good story. No episiotomy, everything, no meds. The midwife was there, but she was not allowed to touch the patient.
Wow.
Even the capacity of a support person, even if she would call herself a doula, would probably be a bad word back then. Who's this person that's getting in my way and telling this patient to do something and just annoying me? No, that's usually what I would see even from the labor and delivery staff early on was you, i.e. a doula, would be an annoyance.
That hasn't changed in some places. There are a lot of places, and I think a lot of it depends on how doulas interact in that space. But yeah, there are definitely some rooms where you get this really undeserved, very cold attention, distant, and just you can just tell, yeah, they're annoyed with you and the role that you're
Yes.
playing and the things that you're doing in that birth space.
No, I loved it. I loved it. I loved the interaction with people to hear where they're coming from. I was never going to put up the wall. I want to hear, and I wasn't going to get any big argument with anybody, but it would just be interesting to see the perspective that someone was coming from. And sometimes it was because they'd been treated badly in the past.
Yeah.
So they come in with that bias against a medical professional because of someone who treated them badly in the past.
Yeah. I've always said that I feel so grateful that I got to practice nearly 10 years as a doula without having my own children and thinking about even growing my own family. And I still don't have children, but I just feel like it really allowed me to carve out this really compassionate and open approach to not judging anyone's choices, because over the years I've just heard so many people's reasons and their backgrounds and their whys of why they make certain choices and why they choose certain things and why they decline certain things, why they request certain things. And it's just it has been, I think, for me, one of my biggest teachers is not having my own birth story when I support people in birth every day.
Yes.
Dr. Martin, thank you so much for being here. So, we're going to wrap up this episode, but we're also going to talk to you in the next episode.
Okay.
And I have a ton of questions still left over. So, you guys, go grab your copy of In Good Hands, and I will see you in the next episode. Be sure to follow me on social media at Tranquility by HeHe and at the.birth.lounge. Until next time, head to your app store and download the Birth Lounge app for evidence-based childbirth education and data-driven postpartum support delivered straight to your phone. Bye. Thank you so much for tuning in today. I truly do value this community and I love hanging out with you. You deserve to have a birth that you love with a provider that values your autonomy and respects informed consent. It's an honor to be your go-to gal when it comes to preparing for your baby. If you found today's episode helpful, share it with a friend. Share it with someone who could use evidence-based information to help them have an informed and confident birth. I'd love to hear what you have to say and read your sweet words. By leaving us a review, you are helping other expectant mamas and their families find the podcast so that we can reduce birth trauma and improve maternity care in the U.S. one birth at a time. If you're interested in joining the Birth Lounge, go to thebirthlounge.com. If you want to connect with me on socials, you can find me at Tranquility by HeHe on all platforms. Until next time, stay educated, stay supported, stay confident. Bye!